Good afternoon, everyone. Are we feeling pumped? Yes, one person is. Let's try that again. Are we feeling pumped? Yeah, that's what we like to hear. Thursday afternoon, you've all had, well, what, over 24 hours of not sitting in the conference room. So hopefully you all got out and enjoyed the sights and sounds of Bali. We certainly had lots of fun yesterday. So yeah, we've got some good photos to show as well. So for those that have submitted those ones, get excited because it is Prize Bonanza Thursday. Unfortunately, it's kind of getting towards the end of the week and it's time to start thinking about, I guess, finishing up, but also excitingly, our closing party on Friday night. So you may have seen it sort of flash up on the screen here and also in the timetable that it's at a different location to the hotel. So it's a Italian restaurant kind of bar called Da Maria, and it's about 2 kilometres from here. There's a few ways you can get there. You can walk, you can drive, or you can scoot. The drive, there is a fair bit of traffic around at that time of night, so it will take sort of around 20 minutes. If you would like to hop in a shuttle bus that we'll have going from the hotel to Da Maria, Locum Life have very kindly organised that one, and if you see Delphine and Max, who will be in the back corner of the room, they have a little WhatsApp code there that you guys can let Choc know that you're keen for that, and they'll ferry people on that bus, which is free of charge. Otherwise, if you're staying out of the hotel or you want to get there early, Bluebird, it's a couple of dollars to get there. It's just the traffic that we have to be mindful of. 7:30 start. We'll have 2 hours of drinks flowing, and we also have some light nibbles, some pizzas and whatnot passing around. So should definitely be a nice way to close what has been an awesome week so far. For today, similar structure to the previous couple of days. We've got 3 presentations. We've got a great mix, bit of stuff in there for everyone. If you would like to re-watch any of the presentations that we have, if you've missed a session, if you want to see slides or specific parts of slides, all that's available through the streaming links that you'll find in our info guide. So as soon as the streaming stops, that becomes a recorded session that you can then watch back at a later date, and that doesn't expire. So that's all there permanently for you guys to view, whereas the e-learning, it's just 60 days that you guys will have to complete that one. Dylan and I are here, so please do ask us any questions that you may have. And yeah, pretty much the structure is we'll get into our first presentation, quick break, and then we'll do our next 2 after that. So without further ado, I'll like you all to give a nice big round welcome to our first presenter, Dr. Christy Graff.
Thanks. Hi everyone, my name's Christy Graff. I'm an orthopaedic surgeon from Adelaide. Anyone else from Adelaide here? Hi, welcome, excellent. Nice to see some fellow Adelaideans. I'd highly recommend not walking to that 2 kilometre place because I went for a walk today and nearly died because of the heat and humidity. It's like you get a bit of a false sense of security in here. Not rickets, not polio. Something we could easily treat in Australia when they're born as a baby. Yeah, clubfoot, yeah. So this is from Africa. This talk is essentially conditions that are familiar to orthopaedic surgeons, familiar to paediatric orthopaedic surgeons, but not necessarily familiar to people who don't do orthopaedics all the time. So I guess this video is to show that we actually have very, very good healthcare in Australia and not many things get missed. So this is just to really raise awareness for those orthopaedic nuances that you might not have seen before. It's a case-based discussion. 68-year-old female who twisted her ankle coming off a step, and these are her x-rays. Anyone see anything alarming on those x-rays? There is some soft tissue swelling. Do I point at the screen? Soft tissue swelling. Oh, that's not going to work. Soft tissue swelling, but apart from that, no gross fractures or anything like that. She was, if people are quite swollen, that is a sign that there's something more going on than potentially just an ATFL rupture, which is the most common cause of an ankle sprain. Does this give any more clues? Can anyone see any injuries on this screen? Yeah, there's a fracture up at the proximal fibula. So this is actually a much bigger injury than is commonly noticed. So essentially on this x-ray there are no fractures, and what happens is that the force of, I'll just see if this, it's just making it, I'm trying to get a pointer but it's just making it dimmer, that's okay. The force that goes through the fracture goes through the, can you see, you can see the mouse there. Goes through the proximal fibula here and then goes all the way through and then out through the deltoid here. So it goes through the interosseous membrane, and it's often missed because people don't think to x-ray higher because the pain is all down at the ankle and the swelling is all down at the ankle, and it's a really significant injury that requires surgery. The clue on the x-rays is what we call Taylor shift. So the distance between the medial malleolus and the talus is bigger than the distance between the talus and the superior margin of the ankle, which is the distal tibia. And I'll show you an example of that in a second. It's often called a high ankle sprain. One of the clues is that patients who you think could probably weight bear aren't able to weight bear. A normal ATFL injury, patients can normally weight bear on the ankle the next day, even though it's a little bit sore. These patients can't weight bear at all because it's unstable. When I see an ankle injury in the emergency department or on the field, or if it's a friend that's twisted their ankle, it's good to examine certain points, and I usually say I'm going to press 1, 2, and 3 and 4, and then you tell me which is the worst pain. 1, 2, 3, 4, and then I palpate the bony fibula over the ATFL, which is the base of the fibula, the fifth metatarsal, and then over the syndesmosis. And usually patients are pretty good at identifying where the maximal point of injury is, and then I look pretty closely at the x-rays for a fracture. The imaging is important. If they can weight bear, I get comparative weight bearing mortise views. Now, I don't know if everyone knows what a mortise view is and the reason we do it, but it's really because the fibula is posterior to our tibia. So if you palpate on yourselves, your lateral malleolus is posterior to your medial malleolus. And so a mortise view is when you internally rotate the ankle so that they're both on the same projection on the x-ray, and it gives you a much better view of the ankle, and you don't get the overlap of the fibula being posterior to the tibia. In South Australia, we have weight-bearing MRI scan, weight-bearing CT scans, which are actually very, very useful for very subtle syndesmosis injuries, because what they do is they map out the surface area of the syndesmosis, they compare it to the other side, and then you weight bear on it and they see if that surface area diminishes and if it's different to the other side, which has been really a game changer for detecting these injuries. You can do an MRI scan, but it doesn't tell you if it's stable or not. And then the other thing is to examine or x-ray the entirety of the fibula. So this kind of just demonstrates the forces that go through the ankle with a fracture or a sprain. So in a Weber A, you can just get a very stable fracture, which is distal to the level of the syndesmosis. The syndesmosis is pretty key in determining how stable this injury is. So in a mesonerve injury, the injury goes through the syndesmosis and disrupts it, which makes the entire ankle unstable. So this is how we stabilise it. There are lots of different ways you can stabilise a syndesmosis injury. We don't repair it because it doesn't really heal very well. It just really scars up in a position that's important for ankle stability. So these screws can break over time because there's little micro movement. Some people now put buttons in, or tight ropes as we call them, so they don't break. Oops, sorry. And I'll just show you the original injury. See, the distance between the talus and the medial malleolus is wider than what we call the superior clear space of the ankle. And then after we repair it, those distances are very similar. So it's called talus shift. And if you see any talus shift, it means the talus has moved towards the fibula because there's ankle instability there. So that's called a Maisonneuve fracture. I think it's some guy called in France that put his name to it. So the second case is a 51-year-old female who's diabetic and was walking and heard a snap in her foot with pain and swelling. These were her x-rays, which were all reported as normal. She also went on to have an ultrasound. For those of you from Australia, it's hard to organise an MRI scan if you're not a specialist. Otherwise, the patients have to pay for it, and so there's a lot of ultrasounds that get done before patients come to see a specialist. And it showed that there was soft tissue swelling, and perhaps they needed an MRI with an orthopaedic review. 5 months later, she had ongoing pain and swelling. So her GP organised a SPECT scan. Has anyone? And it lit up, essentially. There's anything with inflammation is going to light up. So in a 51-year-old diabetic who's got a red, hot, swollen foot with no fractures, does anyone have any idea what this condition could be? It could be infection, and this condition is very similar to infection. One of the clues that it's not infection is when you elevate the foot in this condition, the redness and swelling does improve. The bloods are up though, and the sugars are usually up as well. It's called a Charcot-neuroarthropathy, and it happens in people who are diabetic and don't have feeling in their foot. And pain is obviously a bad thing, but it's actually a really protective feature because these patients who don't have pain then go on to walk on their foot. And I don't know if you can see this, but basically her navicular has fallen out of her foot. And they have these terrible consequences of this Charcot-neuroarthropathy. It's a combination of not being able to feel their foot as well as their bones disintegrating. And if you see a patient with diabetes who presents with a red hot swollen foot that doesn't have any x-ray features, it's important to get them to see an orthopaedic surgeon with an interest in foot and ankle, or a vascular surgeon, to start casting them. This is the CT scan. So that bone at the bottom there is her navicular, which is basically just fallen out and created this big pressure area on the sole of her foot, which she will keep walking on because she doesn't realise what's happening and she can't feel it. And then you end up with this picture where they have ulceration, and this then leads on to inevitable osteomyelitis and potentially amputation. So it's not a commonly known condition amongst emergency services, GPs, and emergency services, emergency departments. And the reason I know this is because I do a lot of the Charcot foot reconstructions in South Australia, and the story is always the same, that they present with this red hot swollen foot, they keep walking on it for months and months, and then they present with ulcers. There are 3 stages: the inflammatory stage where the x-rays don't show anything. However, the MRI or some other like bone scan may show up that there's inflammation around that area. And then there's the fragmentation stage. So the principles of managing it is to cast it with weekly casts so that they don't get pressure or rubbing from the cast until the bones, what we call, consolidate. Because the problem is, if you don't cast it and they keep walking on it, the foot will collapse, and they get these very terrible deformities, and then they keep walking on it, and then they get point loading on the sole of their foot, and a lot of them do unfortunately end up with an amputation. And so how not to miss it is to have a high index of suspicion. In my view, a red hot swollen foot in a diabetic is Charcot until proven otherwise. It's not always diabetics. We see it in like leprosy, which we don't see anymore in different countries, but syphilis, B12 deficiency. So anyone who's neuropathic, and we don't really know why it happens. If you elevate the foot, the redness and swelling can get better. If the bloods are not raging high for infection, if the sugars are not raging high as well, it's unlikely to be infection, but that's definitely one of the differential diagnoses. It's really a clinical diagnosis, and it's a diagnosis of exclusion, which makes it even more difficult. And the treatment's not great either. They have to be in cast for several months until the foot consolidates, but it can be absolutely catastrophic if it's missed. And so that's so it's just really raising awareness for the condition. All right, we're going to go on to some paediatric fractures. 4-year-old girl fall off the monkey bars with an injury to her elbow. So I think fractures generally are not well read or understood sometimes. I don't know, in medical school I do some teaching on fractures, and I think that orthopaedic surgeons aren't very good at teaching or describing how to learn about fractures. Like, we come out of med school or nursing knowing what these bad tumours are that you'll never see, but not knowing how to read an x-ray. And so that's one of the reasons that I come and present things, so that there's more awareness of fractures and what the different fracture types are. So this is a 4-year-old, who's obviously skeletally immature. Can anyone see anything alarming on this x-ray? There is something really alarming, but it's not always obvious to people, especially people who are not used to looking at kids' x-rays. Yeah. So there's a fracture on the lateral aspect of the humerus, which looks like a little fracture because you can't see cartilage. So at this age, most of the kids' elbows are cartilage. And so when you actually open this fracture up, you see this huge chunk of bone that's called the lateral condyle. And if it was an adult, you would be really alarmed. You'd say, oh my gosh, there's like a huge intra-articular fracture on the x-rays. But in a kid, you can't see most of their elbow because it's cartilage. And so there is a huge lateral condyle fracture on this x-ray, but you can't actually see it. That there is the whole fracture fragment here. Can you guys see my mouse? Yeah, great, thanks. And then on this x-ray here, it's this whole fragment here. So often we're referred, like the ED docs will call us and say, oh, I've got a lateral epicondyle fracture, but it's not an epicondyle, it's actually the whole lateral condyle of the humerus which is fractured and come away. And most of them need surgery unless they're like completely undisplaced. These are the second most common elbow fractures in children. Very misunderstood. It's not a supracondylar fracture, and it's often referred to us as a supracondylar fracture, or we see it at 2 weeks in the fracture clinic referred as a supracondylar fracture, but it's a completely different beast. It involves the growth plate. It is intra-articular, and we treat it as such, in that if it's displaced more than a couple of millimetres, we will do an open reduction to fix it. So this is like just a schematic to show you what it may look like. This is a fairly undisplaced one, and all you see is this tiny little sliver here. That's the fracture. However, the actual fracture goes all the way around here. And this is what it looks like in real life. So all of this is cartilage. You can see the ossific nucleus of the capitellum, and this is the entire fracture here. And this is just an outline of how big it is compared to that tiny sliver that you can see on the x-rays. This is one that's a little bit more displaced, but you can see that this is the whole fragment here. How not to miss it? I guess just awareness that it exists. Most people don't even know that it exists. The presentation, the age is almost identical to a supracondylar humerus fracture, so it's very, very easy to miss. One way that you can see it more clearly is if you do an internal rotation view of the elbow and it unmasks the outline of the lateral condyle. You can get an MRI, but in a 4-year-old, that would require general anaesthetic, so that's pretty overkill. If there is an index of suspicion, you just ring your orthopaedic registrar, who also miss them as well, unfortunately, unless they've had some teaching from a paediatric orthopaedic centre. The reason that the prognosis is poorer is because they are intra-articular, and so the synovial fluid goes through the fracture site and they don't heal. Supracondylar fractures will almost always heal because they're extra-articular, but inside a joint you have fluid, and that's why intra-articular fractures sometimes go on not to heal. They go through the physis, they're usually unstable, they do have a tenuous blood supply, so they can go on to AVN as well, and they're often missed. They have complications, largely non-union is the main one that we see, and also malunion because they go into valgus. And unfortunately with the valgus comes the tardy ulnar nerve palsy in later life. So this is how we fix it. We put it back into the right position and we put a big screw through it, and then we take that screw out because it does go through the physis at about 3 months or so. So that's lateral condyle fracture. All right, back to adult land. Case number 4, a 39-year-old man falls off a motorbike and has an awkward fall onto the right foot with pain and swelling. There's so many scooters around here, right? I actually visited the hospital today in Denpasar, and they were saying that most of the trauma that comes in is scooter versus something, which is very unsurprising. So this is the gentleman. He's got lots of swelling over the midfoot. Can anyone see anything on this X-ray that might be unhappy apart from swelling? People are pointing, and it's hard when there's no sound and I don't know your names as well. So I'll show you that there's a Lisfranc injury, which is this ligament here. Has anyone heard of a Lisfranc injury? A few people? Yeah. So it's actually a kind of a fracture dislocation of the midfoot, and Lisfranc was, I think, Napoleon's surgeon or something like that. And then during that time, the guys would go up in their stirrups and push down, and then that's the force on a plantar flexed foot. And so this is the clue here, is on the CT, and that little fragment of bone shows quite a catastrophic injury to that ligament. So there's a very strong ligament between the second metatarsal and the first cuneiform. And that's pretty much the structure that stabilises the midfoot. And so if you go on to walk on this over time, your foot will collapse, and then you'll get quite a bad deformity of your foot, to the point where you might not be able to wear shoes. And it's much easier to fix in the first instance than it is to come back and then repair that. So the stability of the Lisfranc complex is that the second metatarsal is actually like recessed in its little house. So instead of like this one's up here, this one's up here, and the second metatarsal is pretty stable here in his little home. And then that's the other part of the stability of the second metatarsal is this ligament here, which is the Lisfranc complex. So this is an axial view of it, and the interosseous part between the two bones is the most stable. And again, this is what it looks like in a cadaver. How not to miss it? It can range from like a tiny little fleck like that X-ray to the whole midfoot being dislocated. The force on a plantar flex foot is one of the clues, but again, it can happen in a variety of different ways, like a motorbike or sporting injury, etc. One of the main clues is you get bruising on the sole of the foot. There's not many injuries that will give you bruising on the sole of the foot, and if there is bruising on the sole of the foot, then this is one of those conditions. We always get a CT scan. We look for that little fleck of bone, which symbolises that the ligament's been pulled off. And again, I don't think every state has weight-bearing CTs, but in South Australia, I tend to get comparative weight-bearing CTs. And again, they measure the surface area of that ligamentous structural, it is pretty much a joint, and they tell me, okay, it's 10% less than the other side, or it's 20% less than the other side, and then I know that it's an unstable injury to the Lisfranc. An MRI can help. It shows you that there's damage there, but with MRIs, you just see high signal around the area a lot of the time, and it doesn't tell you 100% if it's stable or unstable. Very occasionally, if there is an injury to the Lisfranc ligament complex, we may treat it non-operatively, but again, that's non-weight bearing for 8 weeks or so, which is pretty cumbersome. But the treatment is the same with surgery as well. So if we stabilise it, we tend to keep them non-weight bearing for 8 weeks. So this is how we fix it, not necessarily with this plate per se, but essentially it stabilises the complex between the medial cuneiform and the base of the second metatarsal. It's really to stop the midfoot from collapsing, because if you keep walking on it and you don't have that ligament, your foot will collapse and you'll get very flat and abducted midfoot. So this one is a little bit more obvious. Hopefully you guys can see that this distance from here to here is quite wide. And again, patients are very good. If you palpate that area and you can see the bruising on the sole of the foot and you have an index of suspicion that this injury exists, then it's tricky not to miss. Is that right? It's tricky not to miss because there are lots of indicators as to where the injury is. If you have a fracture through the base of the second metatarsal, the ligament's often intact because the force will either go through the ligament to avulse it or it will go through the bone to fracture it. And to be honest, a bony injury is actually much easier to treat than a ligamentous injury because bone will usually heal to bone, whereas ligaments generally don't heal, and even when we stabilise it, it tends not to heal, but it'll just like heal with kind of scar tissue so that there'll be some stability in that area. If it doesn't heal, then we have to go on to fuse those joints. And the problem with fusing joints, especially in the foot, is that that force that goes through your foot when you're walking has to go through somewhere. And so if you fuse some joints, i.e. the midfoot, then it goes somewhere else. It goes through your subtalar joint, or it goes through your ankle joint, or it can go through your knee joint. And then you start developing pain and arthritis there. So it's not an easy answer of just, we can fuse it, no problems. You then have to realise in the next decade, you can then generate more pain and force through one of the other joints of your foot. So it's not a very happy injury. This is case 5. 11-year-old girl with a 3-month history of pain in the right knee and an x-ray organised by the GP. Again, the x-rays were reported as normal. This is the skyline patella view, which was reported as normal. So the GP, or someone, I can't remember if it was GP now, but someone organised an MRI scan. The MRI scan, again, that's the PCL on your left and the ACL on your right, and they were all normal as well. And to be honest, I saw this girl and her knee examined pretty normal, but she complained of pain there. Reported as a high-riding patella, but if you get an MRI with your knee straight, almost all patellas will be high-riding. Any ideas of what we should be doing next? Check your hip. Amazing. What are you worried about? Say again, sorry? Overweight, yeah, can be. That's okay. I'm about to go through it, so you're definitely on the right track. The ischemia is a different condition. This one's a slip. This one's a fracture. So she was referred to physio for her knee pain. And I don't know why, but some people really feel hip pain in their knee. I saw a patient like a few weeks ago that was put into a nursing home because her knee pain was so bad and no one could work out what was wrong with her knee and she couldn't mobilise anymore. And so she went to a nursing home and then someone decided to x-ray her hip and she had extremely severe arthritis of her hip. So I'm not saying all knee pain is hip pain. I'm saying that if someone has knee pain and the knee is not tender to palpation, there's no swelling, then think about the hip And the hip's quite easy to examine to see if it's painful. If the patient's lying down, you just have to rotate it like that, and that will unmask hip pain. And unfortunately, they still might feel it in their knee when you do this. They're like, and also tenderness in the groin is a real indicator of pathology in the hip. So the physio thought this might be a slip. This is a slipped capital femoral epiphysis. And radiologists miss it. Everyone misses it, apart from paediatric orthopaedic surgeons who see all the missed ones, so then we probably overcall it sometimes. And to be honest, even if this girl didn't have any X-ray changes, I probably would have got an MRI of her hip because of how clinically suggestive it is, and also that you can have a pre-slip when it's about to move. So I don't know if you know what a slipped capital femoral epiphysis is, but essentially the femoral head stays in the acetabulum. There's a physis here, and then there's a fracture through that physis. The ice cream stays in the cup, and then the cone, which I call the femur, the cone starts moving away. Again, we don't really know why it happens. And yes, they are often overweight. There's an index of suspicion of the age group, so 10 to 14 is when they happen. I think the condition with the AVN, that's Perthes, and that happens in a younger age, like usually 2 to 8. So it's a bit of a different demographic. But that also presents with knee pain. So the best way to see it is on a frog leg lateral, which is essentially it's a lateral of the hip where they're lying externally rotated. And then you can see that there's a bit of this, the cone, as I call it, has come away from the ice cream. Here, the ice cream is solidly on the cone. And your radiologist should be able to detect that and pick that up. I don't know, can everyone see that? Can anyone not see it? Say again? No, the radiologist didn't miss it. It was everyone complained. Yeah, their radiologist didn't miss this one, but they are often missed by the radiologist as well, mainly because I think people aren't thinking about it. And so I've tried to outline it quite poorly for people who might not be able to see it. The problem with leaving it, you can leave it. Kids can walk on this. Like this was going on for 6 months. You can walk on it. The problem is that it'll keep slipping. And then as it keeps slipping, the deformity of the hip gets worse and worse. The other thing is that there is a fracture through the physis. So if they then go and have a fall, you can get like an unstable slip where it's just moving around like a fractured femur. And then they get AVN. It's quite catastrophic, young hip replacement, etc. And so it's really good. Like I've seen ones that were missed for 12 months and the deformity is unreal because the patients just kept walking on it with a sore knee. So it is a fracture, and that's why it happens in overweight kids. We think it's an insufficiency fracture. It also happens in children with metabolic problems, thyroid, etc. And the neck displaces from the epiphysis. They can present very differently. Kids can present walking in with a bit of a limp. Other kids come in like screaming in pain, and they're the unstable slips. And again, they're the ones at very, very high risk of AVN, and so we try not to wiggle their hip around too much. They're the ones I don't really want to get a frog leg lateral on, but they come in on the stretcher like this because they're so unstable. It's like a fractured femur. Why do we care? Why does it matter if they've got a deformity of their proximal femur? It's because if they heal in a really bad position, they can then go on to need a young hip replacement. And I've seen kids as young as 10 need a hip replacement because their slip has been missed. So how not to miss it? Definitely the age gives you a clue. So if someone says to me, I've got a 6-year-old with a slipped capital epiphysis, it doesn't happen. Unless they've got some kind of underlying metabolic condition, it doesn't happen. So it happens in adolescents, like 10 to 14-ish, who are overweight, complain of pain in their thigh or their groin. They present with a limp. They present with their foot turning outwards. And the x-rays obviously give the answer, but if it's an unstable slip, if the kid can't walk, don't wiggle their hip around too much, or you can cause AVN. All right, last one. I haven't seen a time yet. So 14-year-old boy from Mildura had pain in the ankle. Anyone from Mildura? Oh, okay, great. Essentially had presented with pain and swelling, had x-rays, sent home as a sprain. Mum said, this isn't right, my kid can't walk. I need to Google an orthopaedic surgeon, and found me. So these are the original x-rays. You can see the massive soft tissue swelling there. Can anyone see anything abnormal on this x-ray? It's pretty hard to see, but if you look pretty closely, there's a bit of a blip here, and it might be projectional as well. So sorry about the poor quality of this. I just filmed it on my camera, obviously, but see this fracture here? And it goes all the way through here and all the way through here. So that there's a fracture line through here, and then it's like this weird zigzag fracture, and then it comes out through the joint, through the epiphysis. And it's one of those funny, nuanced things that only happens as the distal tibial growth plate closes. So generally the distal tibial growth plate will close at 14 for girls and 16 for boys. And there's about 18 months where it's closing. And it closes in the middle first and then medially. So then the lateral side is weaker than the medial side. And so you get these kind of funny fractures. This is another one where the syndesmosis will pull off the lateral aspect of the distal tibia. This one's called a tilofracture. The one that goes through, it's really hard. That's why I showed you that CT, because it's hard to show you without a model in 3 dimensions where exactly the fracture goes through. But because the fracture is, sorry, I'll see if it plays again. Because the physis is closing, this part of it's all closed, whereas this part on the lateral side is still open, and that's why you get this weird fracture pattern through the physis. The physis itself at this point doesn't matter because it's closing anyway, so they're not going to get a leg length discrepancy. The thing that matters is this intra-articular blip here, and so we don't want them to go on to get arthritis. So how not to miss it? The age is a big giveaway. Swelling, again, those 4 points to say, okay, it's not an ankle fracture, it's not a syndesmosis injury, there's something going on with the distal tibia. On the x-rays, if you follow the cortical lines, you can usually see a disruption, and then a CT will give you the answer. We fix it, and then the growth plate closes, but it was always going to close anyway, so the growth plate's not the biggest issue. So this is the summary slide of all those conditions that I've gone through. Hopefully having some awareness that these conditions exist. You don't have to be an expert on major nerve fractures, but just knowing that they exist hopefully raises awareness that we don't miss them. Very happy to link up with anyone on Facebook or Instagram. Very happy to have emails. But thank you very much for your attention.
Thank you, Christy, and really appreciate your time. And once again, if it was a little bit challenging to see any of those slides from the back, they are available via those streaming links if you wanted to have another look at what was going on with some of those x-rays. Let's take 5 minutes, quick tea and wee, and we'll meet you guys here shortly. Excellent.
All right.
Still big control, pretty much. Yeah.
Beauty.
Get moving. Oh, that's okay. Oh, yeah.
I'll wing it. I'll just do a dance.
Music. Sorry, the music. Thank you, everyone, for making that a nice, quick break. As always, though, feel free. There is space at the back if you prefer to stand rather than sit. No problems at all there if you like to move around. Pretty excited about this next presentation. So we've got Mel Gardiner here, who a WA paramedic who was on road when Dylan and I first started and helped show us the ropes. So yeah, it's really nice to have you here, Mel. Thanks for coming to present for us. And let's give a big round of applause for Mel.
Thanks so much, Q. Hi, everybody. Thank you so much for allowing me to be here and share with you a service that I created last year. It's called STORC. It's an acronym for State Obstetric Referral Call. And I launched it on Mother's Day in 2023. Not just because I'm corny, because I am, but really in my heart it was for the women that were going to be mothers in the future of Western Australia. My name's Mel Gardiner. I'm a dual qualified paramedic for 22 years and midwife for 13. And ever since becoming a midwife, I recognised that there was quite a significant knowledge and clinical skill gap that existed for obstetric care in the pre-hospital environments throughout all of the Australian ambulance services. It's really got on my nerves. And so I've decided that with the support of St John WA, I could find a way to make an impactful change, and I have by bringing midwives into the ambulance service. Oh, they should be coming up there soon. Meet the team. Actually, no, have we got a problem with Wi-Fi because there's no pictures? Which will make it really boring for you all. The Wi-Fi is dropping in and out. Yeah, go for it. Oh, do I want to tell a joke or something? I could tell the joke that Nat taught me the other day.
Please don't.
Oh, please don't. He knows Nat too well. Which one, Nat Paruma or Logan?
Either.
Oh, that's unfortunate. We are going to try and do a cahoots at the end of this as well, but the Wi-Fi might actually interfere with that too, so I can't promise you anything. But if we do manage, yeah, that's it. Yeah, beautiful. All right. No, there I am. There we all are. Okay, so meet the team. It's been my honour to share the journey so far with this incredible team of midwives. And not only are they intelligent, passionate and empathetic women, but they have outstanding communication skills and just the right amount of cheek and sass to survive in the ambulance service. The team has earned the trust of St John's WA, so much so, in fact, that they've allowed me to have 2 more midwives join the team. So we were expecting another 2 coming in. Well, one has just started her training and the other one within the next month. So what is STORC? Well, we're a team of 6 midwives at the moment. We offer a 24-hour telephone service. We have extensive knowledge of the clinical guidelines that exist within St John Ambulance. But not only that, we also understand the guidelines that exist in the midwifery field. So things like the community midwifery program in Western Australia, the guidelines that the privately practicing midwives follow or should follow, the WAC sites and the hospitals in the country and regional areas, as well as our peripheral and our tertiary hospitals. So midwives that are usually quite passionate about looking after women have simply extended their reach a little bit further. We look after the volunteers, ambulance officers, clinical support paramedics, critical care paramedics, and even our comms staff as well. So STORC delivers on-scene advice, which is specific to all scopes of practice. And we do this to empower our clinicians to try and deliver women-centred care. We assist in clinical decision-making as it happens, and we provide the most appropriate destination choice for our women so that they can reach definitive care. All of our calls are on a 3-way recorded line so that we can quality assure and make sure that the midwives are giving the right advice to the right people. So maternity care is not our bread and butter. In fact, far from it. On average, St John's attend about 18,000 cases per week in WA, and less than 1% of those is made up of our obstetric patients. So it roughly ends up being about 30 patients per week. These are small numbers, and what that means is that when we compare other areas of our skills, such as looking after chest pains or people that may have had a fall in the nursing home, etc., we really do have that substantial knowledge and skill gap. Maternity cases are seen as low frequency, but they're also seen as high risk, and the perfect environment to breed dread and fear into even the most experienced clinicians. There's a lack of education provided initially, and as continued education as well. So at Edith Cowan University in WA, where I've worked previously, students are fortunate enough to have a standalone obstetric unit, but that's not the case for all tertiary institutions. Once they're employed, you may receive 4 hours within your induction school of 8 to 10 weeks before you're on road, and then not much after that. So we're not exposed to those jobs on a frequent enough basis to be able to build up those skills that we hone as we do for all the other jobs that we do on a regular basis, such as chest pain. And that ends up being something that our paramedics feel unprepared for, they feel apprehensive, and they desire more training opportunities to try and become more fluent in these skills. Now, some of you here today may be aware that from time to time the relationship between a midwife and a paramedic has not always been built on mutual respect or admiration. And in fact, many of my paramedic colleagues quite often dread obstetric jobs, not because of the mother or the baby or any of the fluids that go with it, but actually about the handover to the midwife at the end. I've witnessed both sides with my roles. Some of my birth working colleagues may appear defensive, maybe dismissive, and sometimes even abrasive. I think, though, quite deeply that the problem lies with the fact that we don't understand each other's roles, and we don't realise what we can do and what we can't do, where we excel, where we feel limited, and where we feel vulnerable. STORC for me is that glue that can bring the different streams of healthcare together for better care for mum and bubs. So women educate, midwives educate, oh, hang on, I can't get this to slide up. That's all right. Midwives educate women, they listen to them, they are understanding of their previous trauma. They also give them time to process the information that is given to them when they're in a birth situation so that they can make informed consent. And from time to time, they're having to shield them from perhaps something that might be considered an unnecessary intervention. But what do they know about the ambulance crews that they meet? What do they know about their knowledge or their skill set? What training have they had? And what about their individual or personal experiences? What if the only job that paramedic has attended before had a really poor outcome? Or what if that female volunteer is struggling with her own fertility at the time and then is called to go and attend a miscarriage in the community? How about that paramedic who just watched his wife have their first son and then had a massive postpartum hemorrhage? He didn't even realise he was triggered by that case until the next labouring woman stepped into his ambulance. So I guess STORC is there not just to provide that clinical experience, but also to soften the two as they work together to try and deliver that collaborative care for the woman. The results so far, well, we've been up and running since May 2023 and we've done 170 plus cases. In fact, while I've been here throwing down Bintans and buying some awesome Birks at the markets, we had 5 cases yesterday. We had 3 babies that were born and 2 other women go in with some antenatal conditions. About 10% of our cases come from regional and remote areas, and we've had more than 30 babies born in our care. We've definitely had our mix of really complex cases, as you can see from the slide here. And I don't think any midwifery or paramedic discussion about obstetrics could probably go without a mention of free birth. Does anyone here know what free birth is or maybe doesn't know what free birth is? A little of each. So free birth is the intentional decision by a woman to birth outside of the medical model. So that means without the care of a midwife or an obstetrician or a shared care GP or anything like that. Quite often these women will come in and they'll have their ultrasound just prior to 20 weeks, which is an anatomy and physiology ultrasound, and then they will completely step away from the medical model. Unfortunately, what that means is that when things go badly for these women, we are often the ones that are called in their darkest hour. I've seen not just anecdotally with STORC, but I've also starting to see the research that's supporting that free birth is on the rise, particularly after COVID happened. And I guess the people in this room, it's very easy for us to understand and appreciate that we trust the medical model. We are lucky enough to work shoulder to shoulder with some amazing clinicians, nurses, doctors, specialists, paramedics, anything within the hospital system. We know that there are so many dedicated individuals that give of their time freely and their heart for the goodness of others. But for these women, they look at what we do as intervention. They look at us taking away their liberties. They look at us and think we're not listening to them, that we don't validate their concerns, and they see us as a threat. So they choose to reject the healthcare system. It may be because they've had a previous trauma. It might be because they had some childhood sexual assault trauma, and perhaps the idea of having to go in and have multiple strangers do a vaginal examination on them is more than what they can stand. It might be that they simply desire a physiological birth so strongly that they don't want anyone to interfere with that. It could be that they can't access the care. For a lot of regional and remote women, if they're living in an area where the hospital doesn't provide maternity services, they may be taken from country and sent down to Perth to have their baby. You can imagine for First Nation women, if they were told to leave their family to have baby number one, they're probably not going to go for any antenatal care for subsequent pregnancies. And for some people it's a cost thing, they simply can't afford to get a midwife or an obstetrician. And for some women, and we have a couple of small groups that are kind of speckled, particularly south of the river in Perth, they believe that it's the way, and they believe that their religious beliefs will take care of their baby, or their cultural beliefs, or their belief in themselves. Now, sadly, in some cases, we know that we don't always get to keep our babies. STORC has conducted debriefs for crews that have struggled to process births that they've had to respond to. They're saddened by these unfortunate events and the devastating losses that sometimes are exacerbated by feelings of inadequacy due to the lack of education and training that I discussed earlier. Sometimes the decision might have been by the woman and perhaps not even the partner that she's birthing with. And sometimes we pick up on that kind of unease within the household. And so it's been probably one of the most crucial parts that I've played in STORC, is to go through with these crews and help them to debrief after attending these cases. All right, so I've got some case studies for you. But before we do that, let's get you all in the mood by going through a video. Yeah.
I gotta push.
You gotta push? What do you mean you gotta push?
Something feels like it's coming out.
Holy shit. Holy shit. Babe, do I need to pull over?
I don't know.
Hey, Erica.
Hey, it's Troy. We're 11 minutes out. She feels like it's almost coming out right now.
Maybe coming. Okay, where are you?
We're 407 Brock Road. I'm 11 minutes away.
Okay, if baby's coming, you gotta pull over and call 911.
Babe, is the baby coming?
Yes!
Okay, I'm pulling over.
Pull over and call 911.
Okay.
I'm gonna stay on the phone with you, okay? Can you use another phone to call?
Yeah.
Okay, Erica, it's okay.
Ring of fire!
Okay. Is the head coming?
Yeah!
Make sure your pants are off.
Pants are off.
Want your seat back. Give yourself lots of space. The fire in the ambulance.
I'm having a baby on the 407.
So let me put you through the ambulance.
I can't catch it.
Please help. Please help.
Ambulance, what is your emergency?
I'm having a baby side of the highway right now.
Okay, where are you located?
407 and just past Brock Road going west. I can see the baby's head. The baby's head is out.
Okay. You pulled over, yeah?
I'm pulled over on the side of the road, yes.
Okay. And sorry, which direction you are going? West?
I'm going west, yes.
It's coming out.
Okay.
It's coming out. It's almost out. Tell me what to do, please.
Okay, don't pull on anything. Do you have a clean cloth, clean towel, blanket?
In my bag.
Okay, any blanket?
Just put the baby on me.
No, you're on the phone with your midwife. I'm gonna
Baby's out, baby's out, baby's out, baby's out. Baby's with mommy. Jesus.
Do not hang up.
I want you to hold the baby against your chest, Erica.
Yeah.
What's the vehicle description?
White Dodge Ram. White Dodge Ram.
Is the baby crying, Erica?
No,
No.
not yet.
Okay, you're doing a good job, okay? Tell her to take slow, deep breaths. Do not pull on anything.
Not pulling.
Okay. Is the baby crying? Wipe its mouth.
Yes, thank God.
Great job. All right, you want the baby to cry. You did a great job, okay? How's mom doing?
I'm fine. I'm fine.
Okay, is this your first child?
No, third.
Okay. And is it full term?
Yes.
This one?
Okay.
Yeah.
Good job. Okay. I have an ambulance on the way to check on both of you. Do not hang up, okay?
Okay, thank you.
Okay, and the baby's crying. That's beautiful.
I love that video. It never gets old. That's also why the third child is called Third the Turd, because they don't care what the rules are. They're just doing whatever they're doing. All right, so let's go into some case studies. So case study number one, I've permission obviously from all of these people to share their stories if there's their name in it, obviously, and photographs of them. Amy was having a precipitate labour at home. She's a G5, P4. She's 32 weeks pregnant at the stage that we met her, and she's having twins. She made a phone call. She actually got her children set up in the morning. So she's got 3 boys that are currently at home with her and another boy that lives in New Zealand. And so she set the 6-year-old up to feed Weet-Bix to the 4 and the 2-year-old because she started to get a little bit of a niggle. And she went to call her husband and say, you might need to come home from work. And he said, no worries, and said, I just got here. It's pretty inconvenient, really, is what he kind of came across as. And she had another contraction while he was on the phone, and he said, you aren't going to make it until I get home. You need to call an ambulance. So she rang STORC. She rang the ambulance, and then the crew rang STORC straight away. And a couple of our crews are now having us on the phone on speaker, and they'll just put it in their pocket. So the crew walk in, they see the boys in the kitchen, they're having some breakfast. They're like, hey, fellas, where's mum? They're like, all right. They're like, oh, okay. So they walk through the back of the house. It feels like a hoax. So they're thinking, I don't think there's actually a woman here having twins. Sounds kind of made up. And they keep walking through. They end up finding her in the front of the house. She's actually in the ensuite. She's put herself behind the door, and the first twin has already been born. So the first twin was born with the call taker on the phone. STORC and the crew walk in for the next one, and the cord has stopped pulsating for the first twin, and they're about to clamp and cut that one so that they can kind of pass out to the other crew so that they can have a good look at this little guy. And all of a sudden she says, no, I've got to push again, and she births a second twin. And then the second twin is being examined by the paramedic, the midwife's talking her through it. She said, no, here comes the placenta, and out it came. So within 18 minutes, she birthed 2 twins and a placenta, which is pretty remarkable. After that, STORC midwife had noticed that she could hear some grunting in the background and asked if the paramedic could check on the twins. We found that the second twin was quite cyanosed and having a little bit of respiratory distress, so she asked if they could get moving with that baby on a priority 1 to King Eddie's, and mum ended up following with twin number 1. Once the baby got there, we found out that he actually had a little pneumothorax, and that's why he was struggling. And that's a little media thing that we did a couple of weeks later when they finally came home from the hospital. When I got to know Amy a little bit more, I actually found that it's quite remarkable that these twins made it as far as they did. And she was having MCDA twins. Now, what that means, and what you can see from that picture there, is inside the uterus, there's almost like a balloon that goes around the outside of your baby. The chorion is the one on the outside, closest to mum's uterus, and the amnion is on the inside. So twins that are considered MC means monochorion, so one big bag around the two babies, and then diamnion means two membranes on the inside. So they're safe from each other as far as they can't grab each other's cord and things like that. But unfortunately, their danger is that when their placenta's forming, it can accidentally have an anastomosis of the blood vessels. So instead of a blood vessel coming back from the baby, going into the placenta into a capillary network, in fact, it's been interlocked with one of the blood vessels that leads to the other twin. So what you end up having is one of these twins who becomes the donor twin because it's not getting as much of a blood supply, and they will have only a little bit of fluid around them. It's called oligohydramnios. And the second twin, who's quite the hoggy little man, will end up being a lot bigger. He will end up having a lot more fluid around him, called polyhydramnios. Now, in this situation, it's not the smaller twin that's at risk, it's actually the bigger, because all of that extra fluid means that his kidneys are distressed and also that he's at risk of developing some organ failure from an enlarged heart. So it's not unusual for women to have these twins early just to kind of make sure that they're safe. Some of the treatments that you can have when you do have twin-to-twin is an amnioreduction, which is where they'll go into that polyhydramnios twin and they'll drain some of that fluid away. So Amy had to go in before she got to 20 weeks when they had already diagnosed these twins, and she had 2.7 litres of fluid drained. Now, you're only supposed to have a litre of fluid around each baby at full term, and she wasn't even halfway yet, so that's quite substantial. They also did the laser diathermy to correct the blood vessels that were intersecting, and then 3 weeks later she had to go back in for another amnioreduction of about 1.3 litres. These interventions, I suppose, don't come without their risks, and so she suffered a few other little things as well. She had an antepartum bleed, which we heard about from Matt and also from Christy on day one. Was it Christy? Yes? Caitlin. My apologies, Caitlin. And so she also had threatened preterm labour. She went in with some contractions one day, and then there was another time where she ended up going in because her membranes actually ruptured. The hospital said to her on the Sunday evening, I really think you need to stay in until you have these babies. I don't think that if you go home, you'll make it back here in time. And she said, my husband's due back at work on Monday. I have 3 boys at home. We don't have anyone to look after them, so I will be going home on a Sunday. So she discharged against medical advice, and come Tuesday morning, the hospital were completely correct and she didn't make it past her own bathroom. These are little boys now, absolutely gorgeous. No. There were some other photos that were supposed to come up, but that's malfunctioning. Next case study was one that I actually did myself, and at 3 o'clock in the morning we received a call, which is when all of my calls actually happen, because babies like to be born between midnight and 6 a.m. And it was for a 17-year-old female in regional WA. This was her first pregnancy, and she'd been sitting on the toilet with some abdominal pains. She thought maybe she had a bit of gastro, until a foot fell out, and she realised it probably wasn't the problem after all. The call taker was still talking to the family, and when they rang me, I asked to be put straight through to the scene. They said that it was so chaotic with the family that they couldn't actually get any information from them, and they were struggling to understand. So instead I got to speak to Jack. Jack was a volunteer that was heading to this case, and he's a 24-year-old guy. And I said to him, mate, I need you to walk in. It's a pretty chaotic scene. You need to tell them there's a midwife on the phone, and you need to really give them the confidence they need to trust you. I could hear some of the voices in the house when I was in Jack's pocket, and I could hear that they were definitely a First Nations family. And I said, Jack, you need to find out who the auntie is and ask her to come to hospital with this woman. That is easily the quickest way to be able to help. They did believe everything that he said, and they followed him quite happily. We walked her straight out, and we got her onto a stretcher into all fours, and she got another contraction. So we asked her to push until we could get this baby out. And keep in mind, we weren't really sure how far along she was. Oops. And so she managed to push that baby out in the stretcher, and I had to ask Jack to resus that baby. The baby was quite small, and I started to ask him a few questions like, is it as big as your iPad or is it smaller? And he said it's about the size of my phone. Not great news. I asked him if he could see if the eyes were open or if they were transfused shut, and he said they were shut. I asked him if he could tell me what the skin looked like, and he said that the baby was pink initially, but it had gone purple and quite see-through as soon as it was born. We had to take the mask off the BVM that we had because it was too big for this baby's face. And I said to Jack, I am fearful that this baby is not viable, and I'll explain what that means to you later. And he said, great, because I don't know what that means. And I said, but I really need you to resuscitate this baby. It may not be because you can save this baby, but everything you're doing now is to help this woman process a loss. And he went, okay. So he resuscitated that baby for 5 minutes on the way to hospital. I'd also gotten comms to get in touch with MOETS in the background. MOETS are a segment of the WACS service, the country service, and it's a midwifery and obstetric emergency telehealth service as well. But what they can do is they set up an obstetric consultant to be on a video conference as soon as they entered the hospital. So as Jack went in resuscitating this little baby, they had the obstetrician on hand, and he was able to confirm that the baby was only about 20, maybe 21 weeks. And so they were able to stop with the resus activity. But what he was able to do for me as we approached the hospital is I said, Jack, I need you to look up and I need you to make eye contact with this woman and I need you to ask her if she's okay. And he did. And then he looked up a few minutes later and I said, now I need you to ask her if she can check if she's bleeding and make eye contact and talk to her again. And he did. And the reason I did that is because as paramedics, we become very flowchart orientated when we're distressed. If we're in a situation that is uncomfortable, we flip into ambo mode and we have the ability to forget the human that's at the other end of that tragedy. And it's a self-protection mechanism, but it could be done better. The next day we ran a cold debrief for Jack and the other crews that were involved. And then eventually I was able to go up and see him for myself. We ended up having an education day and did a cold debrief for all of the volunteers, because a job like that can usually have a ripple effect and you can lose volunteers quite quickly if they think they're going to be exposed to it. So this little bubby was extremely preterm, and there's some of the kind of information there that we see with our very preterm babies. Their skin will be very thin and shiny and pink. A very small size. They will grow in an asymmetrical fashion until babies get to about 34 weeks. But before that, they will be quite asymmetrical. And I talked about viability earlier. Viability is that kind of date that we put on when we can actually actively resuscitate a baby. And it's at 23 weeks. And the reason for that is the alveoli at the end of the lungs aren't formed until then. So you could have a paediatric anaesthetist in your pocket. It won't matter, because if you ventilate and you tube that baby, there's nowhere for that oxygen transfer to occur. Now, not everybody is able to tell us what their gestation is in STORC, and so there's a little trick here that you can use if you need to. It wouldn't have worked for that lady because the baby was already outside the pelvis, but if a woman is in labour and if you were to feel her fundus, which is the muscular band of muscles at the top of the uterus, it's the powerhouse and where the contractions come from when we're labouring. If you feel that shelf and it is at the line of her belly button, she's going to be about 22 weeks pregnant, which means she's quite close to being viable. If you then measure a finger breadth or centimetres above, every centimetre above that belly button is equivalent to another week of gestation. So it's a nice, quick, easy way on the ambulance where crews can work that out. Another case that we had, there was a woman, she was 32 years of age, she was 36 weeks pregnant, it was her first baby. She'd woke up at 3 o'clock in the morning, she was feeling a bit nauseous, she had some headaches and she was feeling generally unwell. The only things that she'd been diagnosed with was some hypertension during her pregnancy, and she had no other past medical history. Unfortunately, the family gave us a call because at noon she had a 3-minute seizure, tonic-clonic in nature. The call that came to me that day was actually from our SOC, our CSP, our clinical support paramedic in SOC. The crew that were going to it were known to be just a little bit difficult, might be a nice way of saying it, maybe not open to hearing other people's thoughts or maybe some guidance. And so the CSP took it upon himself to ring and get my advice anyway. I told him to expect that if they got there, the observations might be quite normal because having that seizure can almost like reset that woman. But this was definitely going to need to be an urgent trip to hospital. When they got there, these are the observations that they found, and they said that they would have actually just gone at normal traffic speed because they didn't think anything was wrong. The problem with this scenario is that she's had a seizure and she has very high blood pressure. The blood vessels that go into the placenta are quite wide, about this kind of size. For example, if you have blood pressure that is under a lot of pressure, the blood vessels that go into the placenta are much smaller. So now you're pushing all of this blood through an even smaller pipe. And what can happen is it can actually blow the placenta off the wall of the uterus. Now, all of those little areas that can happen is actually an area of infarct. And if there's a lot of those going on, then it's reduced blood supply to that baby. So quite often women with high blood pressure will have growth-restricted babies, and they're certainly at risk of an abruption, which is what I was worried about with this woman here. Case study number 4. This woman actually ended up being a repeat customer for us. She rang with her second baby, first of all, because she was labouring and she needed to go to Armidale Hospital. Unfortunately, we were told Armidale were on maternity bypass, which is something that can happen, and the crew started heading towards Fiona Stanley. Fiona Stanley took the call and said they'd accept the patient, and then rang back and said, actually, no, we've just rung maternity at Armidale, and they're only on maternity bypass for new patients, not for existing patients that are booked to them. So now we called the crew back and we asked where they were. They were actually much closer to Fiona Stanley, so we took this woman here and she ended up having her baby there. She was concerned because she'd had her first birth as a caesarean section, and so she was going to need a little bit of extra attention to attempt a VBAC, which is a vaginal birth after caesarean. Anyway, she actually had a lovely time at Fiona Stanley, and so she booked there for her third baby. And we ended up getting a call for her third baby. So this time she decided to hire a privately practicing midwife and a doula so that they could talk on her behalf, because she just wanted to labour and she just wanted to do her own thing without all of the distractions of the potential for things to have gone wrong, which happened for her first 2 births. And then what happened is she was quite low risk. She was 39 weeks pregnant. Everything is going well. She ruptured her membranes at about 4 a.m. She didn't start to contract straight away. Her Lycor was clear, so there's no problems there. And then her contractions started to just niggle away at about 5 o'clock. She was labouring at home. She rang the doula and the midwife to let them know, but said that it was just very early days yet. And the doula thought, well, I might actually head on over because she's had a rough time and she could just do with a bit of support. When she got there, the grandmother, let her in, and the doula was sitting and the woman was outside in the shower having a bit of a wash and just having some pain therapy from the water. And she said, I can feel something drop into my vagina. And the doula thought, what do you think it is? She said, I've got no idea. And she asked her to have a look, and so she stepped around the corner and had a look, and there was a cord that had prolapsed out at her vagina. The doula also said that there was a little fist at the opening as well. So there was now an ambulance on the way for this woman again, and I also took this call. And initially what we said was that we were going to, and I don't need to tell you about cord prolapse because actually that was done on day 1, which was quite handy. I guess the only thing I would outline here is the malpresentation, being that the hand was coming first, was probably why this woman had a cord prolapse. So we would usually try and get this woman into an exaggerated Sims position. We may need to insert 2 fingers to push that baby away, and we would try and get her to theatre. Unfortunately, being that this wasn't this woman's first birth, it was actually her third baby, she was already involuntary pushing when I got on the phone and could hear her in the background. So I got her out of exaggerated Sims and I said, we need to get this baby out and you need to start pushing. Only 30 seconds later, the crew and the midwife walked in. The midwife took one look at her and said, you need to push like hell. And she certainly did, because a minute later that baby was out. He was quite shocked though. He came out blue and floppy. He had no respiratory effort whatsoever. His heart rate was 167, which is great. So we started to resusc this little guy with cord intact. We were giving him ventilations, and his APGAR score at 1 minute was only 4. His APGAR at 5 minutes was only 4. The midwife was looking after the woman and gave her some Synto into the leg, and the placenta was delivered at 8 minutes, and at 10 minutes his APGAR was only 4. So at this stage I asked the crew to get moving, and before they left I wanted a temperature. Now, unfortunately, we use tympanic temperatures in the ear for babies, which is ridiculous because they're too big and they don't fit. And I've been working on a business case for some time, and this little job fell in my lap, which was quite serendipitous. His temperature was only 35.4. Now, that is considered severe hypothermia. And the problem with that is that if we have got... Oh, spoiler alert. The problem with that is that babies that are too cold start to get very, very distressed very quickly. And babies can lose heat from all of these 4 sources. So if you don't have the doors closed and you've got some drafts that are moving through, you'll lose it through convection. And if you haven't actually dried that baby properly, and the sweat, kind of is on mum as well, and then you put that baby skin to skin and she's cooling down, you can also end up losing some heat to conduction. We need to dry these babies thoroughly, and also keep an eye on their respiratory efforts because they can lose moisture and heat through their evaporation as well. And we'll always put a beanie on and try and use warm towels around babies to preserve their temperature as well. What we do have, now that I knew how cold this guy was, is I asked them to crack one of these heat packs, these ready heats. So similar to, the ice packs you can get out of your first aid kit that will snap cold, these do the same thing, but they're hot. So they will heat up to 40 degrees. Now, you can't put them directly on the skin of a baby, but you could put a dry towel or a sheet and then you can put the heat pack over the top. So for the trip that they took, we decided that even though the closest hospital was Midland at only 14 minutes away, we needed to go to Fiona Stanley, which was 21 minutes away. And the reason for that was I knew this baby was going to need some active cooling to recover from these resus efforts. En route, the baby managed to pick his temperature up and he was normothermic by the time he got to Fiona Stanley, and quite, well, unsurprising to me, his rest rate picked up and he was actually breathing spontaneously on his own at about 36 breaths per minute. He spent a few days in hospital having some cooling and a few more days just recovering from all the different blood tests, etc. he had, but he had an MRI and an EEG that was completely clear and he's discharged home with mum. Case number 5, we had a woman who was having a planned home birth and she had 2 midwives in attendance. She again was a primiparous woman, so first baby, and she'd ruptured her membranes and the waters were clear, so that's good news. Everything was progressing well and the midwives were happy until they decided to do a vaginal examination to check her progress, and instead of feeling where the baby's head was, they felt a squidgy little bottom. It was 45 minutes to the receiving hospital. So they called an ambulance straight away. I was the STORC midwife on this one as well. And I actually knew both of the midwives that were on scene. And so I said to them, you've got a choice. You can get to Joondalup, which is 10 minutes down the road, or we can push for King Eddie's. And they're connected with King Eddie's, and King Eddie's are actually a bit more open to allowing vaginal breech births. So I said, do you want to head for there? And they said, absolutely. So the CSP and SOC got on the phone to the police and Main Roads, and we got a green light pass to go through, which is shit from the movies, so that's kind of cool. They made it to the birth suite, and all the staff that were there continued to contribute to her care, so the midwives stayed with her. And she continued to labour, but she really hadn't progressed too much from leaving the house. So with that information and also having the time for the midwives to explain her what our options were, they said, you can either continue to try for this vaginal birth or we can take you for a caesarean section. She decided to go for a caesarean section, and both the baby and mum were happy and well and on the ward the next day when I caught up. So breech happens about 1 in 20 pregnancies after 35 weeks. And the reason that I say after 35 weeks is because babies usually don't turn and go head down until about that time. So it's quite common if there are preterm births, and certainly what I've seen anecdotally through STORC, for a baby to be breech if it's preterm. About 30% of these are diagnosed in labour with that same experience that the midwife had, where she's either done a vaginal examination or where she's just actually seen a couple of butt cheeks presenting at the vagina instead of a head. Babies and mothers that are breech, unfortunately, have higher risk of poor outcomes regardless of the birth that they choose, so whether that's a vaginal or a caesarean section. But the one thing that I do want you to take home from this is that now we have a lot more understanding about physiological breech birth. We're starting to slowly recover from some of the practices that changed when a horrible study called the Term Breech Trial came out, which was just basically full of shit, pardon my language. So with a physiological breech birth, the great things about that is that we can actually see the condition of the baby and we can make some judgment calls as we go. Now, the interesting thing is that, remember I was talking to you about the fundus earlier, but when the fundus gets to the height of the pelvis, that fundus is no longer the powerhouse of those contractions. In fact, it thinks that it's empty and it will start to progress into third stage, meaning that it will start to actually release the placenta. The problem is that the head is still stuck in that woman's pelvis and the birth has not been completed. So if you are happening to look after a woman who is birthing their baby breech, you need to instruct her to keep pushing even if she doesn't have those contractions there. Because in this situation, time is brain, and we really need to get that baby out probably 7 or so minutes after you first see it rump. And so I say rumping because it's the butt cheek that appears first rather than crowning, which is the head. I did want to touch on this only because it came up a couple of days ago. And the obstetrician said hands off the breech, which is true. Mary Cronk back in 1998 said that, and she was a midwife that was involved. She regrets ever saying that and hates that she said it because it's been understood the whole time. So as a result of knowing and learning a lot more about physiological breech births, unfortunately clinicians that have kind of stuck in this hands off the breech scenario have failed to intervene when an obstruction may have been picked up. And the problem with that is it can lead to some poorer outcomes. So there's a Sean Walker, who is a doctor, as in PhD doctor in physiological breech birth, who has now coined the term respect the mechanism, and there are 10 steps in physiological breech birth, and restore the mechanism. So in other words, and paramedics are very good at doing this, know what the normal is and what it should look like, and when it deviates from that, there are a set of manoeuvres you can do to rectify it. Another case that we had was in, again, a remote location. This woman was a gravida 9, parity 8. So she's had quite a few babies. And again, at 32 weeks, she'd gone into threatened preterm labour. The crew that turned up for her are a double volunteer crew, and they were a little bit further out. We knew that this woman had ruptured her membranes about 24 hours earlier, and she was now starting to have contractions as well. It was a little bit difficult to get a history from this woman. Again, I was the person on this call. Sounds like I'm a bit of a shit magnet, doesn't it? But I guess that's fair. And the last 4 births that she had were actually caesarean sections. But unfortunately, she didn't know why she had to have those caesareans, and neither did her partner. So this was a concern for me, and the blood pressure that I noted at that stage was 90/60. So I organised a halfway meet where a paramedic crew could attend and meet them on the way, and they were going to transfer that woman on to a regional hospital. I'd also contacted Mowat's to let them know that there was a woman coming in, and they were able to look into their resources and find out that the previous caesarean sections had been because of infection and a breech presentation and things like that. They weren't because of high blood pressure, which was the only answer that we'd been provided by the family. When I called back to speak to the crew again, it was now the paramedic who had taken over from the volunteer, and he informed me the blood pressure had dropped to 80/50. I wasn't happy with that. He said that the woman was also starting to become a little bit drowsy and wasn't being quite as cooperative with her answers anymore, and she appeared to be moaning in pain. I asked him if he could do a palpation for me, and I was worried about a placental abruption or perhaps a ruptured uterus where the baby had come through her previous caesarean scar rather than being pushed down towards the vagina. He did a palpation and he said that it was all soft and that she didn't really trigger to any kind of pain response as she did her palpation. But then he did another blood pressure and found it was now 70/45. Her rest rate was also starting to pick up, so I knew she was bleeding, I just didn't know how or why. I rang back Mowat's and told them that it wasn't really a birth that they were going to be expecting at this regional hospital, but probably something much worse. And they were all ready and prepared on the video conference when they came in. They ended up priority wanting that woman out of that hospital. She went via Royal Flying Doctors and ended up at King Eddie's. Very sadly, however, she did lose that baby. She had suffered both a placental abruption and a ruptured uterus. The baby had been born into the abdominal cavity and had deceased. She lost 3 litres of blood and had to have her uterus removed. But she's alive because of the combination of those people that work together. Do you want me to skip ahead to... I've got a breach video here that I just want to show you all before we kind of wind up. Do you want me to try and do the cahoots cue? No, okay. All right. I have a breech birth here that I want to show you.
Yeah. Keep her coming. Keep her coming. You're doing it.
Yes, Christy. Yes, Christy.
You're doing it, baby. Almost. Her arms are out.
One arm. 2 arms.
Yeah, baby.
Nice strong push.
Yeah, baby.
That's it. Yes, Christy. Keep coming. A little bit more. She's almost there. One more. Good. She's trying to breathe.
Yeah.
Nice and strong.
You got it, baby.
You're almost there. Go ahead. Here she comes.
You got it. Oh. Yeah, she's so good. It's our baby girl.
Oh my gosh.
Come on.
Such a nice color. Go get some warm towels for her.
Baby girl. Oh, there you are.
One thing I've noticed when people become stressed is their voice becomes a little bit louder and a little bit higher. You might have heard from that dad's voice, it was quite high. I can usually hear it when I'm on the call. So thank you, everyone. That's my talk today. They're my beautiful kids. Any questions?
Got time for 1 or 2 questions. If anyone has anything that they'd like to ask Mel?
Yeah, this is only in WA at this stage, but I presented at both the National Midwifery Conference and Queensland have hit me up. There's a dual paramedic midwife over there who has become my best friend, and South Australia, someone's reached out to me as well. So I'm hoping it might go national.
Awesome. Let's hear it for Mel. I'm sure Mel won't mind either if anyone's sitting back listening to that thinking, geez, this would go well in our service, and you'd like to connect Mel with some people that you know. I'm sure it would be great to see this project get moving. So feel free if you guys need to stand up, if you need to grab anything, but we will kind of move on to our final presentation quite shortly. Before we do, it's Prize Bonanza Thursday. So let's get some photos up and try and give away some prizes. So bear with me for 1 second here. All right, so I think we have 4 prizes to give away, and Dylan's picked the top 6 or 8 or so photos. So almost every second person gets a prize. Hopefully you all know the rules by now. The loudest cheers wins. So Sunset Beer, what do we reckon? Sometimes all it takes is 1 cheer to win a prize. Oh, wow. That's pretty cool. If you can't read that, it's me when I'm late to the EMS conference session. Very creative by someone out there. Oh, another beach sunset photo. It looks like from the cruise last night. Oh, getting the beach bag out. It's good to see it being used as a beach bag. Oh, some exercise in the sun yesterday. Oh, on the way to the conference, having a nice little nap. Oh, wrapping the emergency fit towel. Oh, there we go. I think that's got to be worthy of a prize there. Chris in the next, just for you there, Mel, for the STORC presentation. All right, so we've got prize to Chris. Let's go a prize to whoever's posted that one. Sorry, we don't know the names. And another prize for this one, because that was a good cheer. So there we go. Let's give away those 3 prizes. And well done to everyone for getting those photos in. Still not too late. I guess we've got an extra prize again for tomorrow. So that might be our Prize Bonanza Friday as well. So if you're happy, Drew, I might call you up and let's give a nice big welcome to our final presentation of the day, Drew Aris.
I haven't even started.
There we go.
Does anyone else want to leave? No? Hello, everyone. I told the cameraman that I tend to pace a bit, so I'm going to see if we can catch up with me. This is just, hopefully, my whole goal here today is to plant some ideas in everyone's head, and then hopefully you go home and learn a little bit more about it. I did this last year in Queenstown, and I only listened to myself yesterday for the first time because I didn't really like it. As in, I didn't like to listen to myself. And I actually swore a little bit without thinking, so apologies if that happens again today. I'm a paramedic, I'm not a speaker. I am nervous. I asked Dylan, I'm nervous, mate, any tips or tricks? And he said, picture the audience naked. I said, it's 2024, you can't picture people naked without their permission anymore. So, thankfully, I have some good friends. Ben, can you stand up for me? Ben is going to be the person that I picture naked for the rest of the night. Thank you, Ben. He's signed his contract and everything, so it's all good. Okay. So I'm here to talk about something called crew resource management and how we can bring that into healthcare and what we can really learn from the aviation industry. Everybody, I think, has an origin story. I'm a bit of a human factors nerd, but I never really knew why. As a kid and today, I used to watch that show, and no one could really figure out why. It's got nothing to do with charred corpses and things, or crashing planes or anything like that. And last time I gave this, we talked about crashes just before everyone was about to fly back to Perth, so it was great. But no, it's because in the aviation industry, if something bad happens, there's a massive investigation, and the whole point of that investigation is to make sure it doesn't happen again. Nowhere else do they put as much effort into trying to make sure disasters don't happen twice. So instead of just thinking that I like seeing crashing airplanes, which I don't, it was more about that human factors side. And then the older I got, the more I realised that's exactly what it was. Really quickly, who am I? Again, paramedic 2009. I worked as a clinical support paramedic from 2019 to 2023. If you're not from WA, you won't know what that is, but I kind of explain it quickly later. And I'm currently a community paramedic in Onslow, which is a remote town in northern WA. Does anyone see anyone they recognise? No? No? Yeah? It's a very, very young Dylan and Quinton. Look at the hair. Look at the hair. Okay, so the only reason I'm putting this all in there is because this presentation is more about a journey and then where I've actually ended up to. So spent a good 10 years as a paramedic and then went to a clinical support paramedic. Clinical support paramedic, you spend half your time with a headset on, like that, answering calls from crews, volunteers, hospitals, dispatching helicopters at that point, doing all that sort of stuff in a really chaotic environment. Everyone says that men can't multitask. I've heard no one can multitask. It's just they do lots of stuff poorly. But within SOC, our operations centre, you have to learn to multitask or you're not going to be very good at the job. So I had to learn to use the people around me and to actually get better at multitasking. The rest of the time, I was in a car that looked like that, going to a lot of like trauma and people that aren't breathing. Over the 4 years, did about 1,000 jobs within that vehicle where I'm backing crews up, and about 200 of those were active resuscitations. So that's not a brag, that's just saying that I had really, really good opportunity to learn how to work within a team and to get some cool stuff done. And then finally, that's me sitting up top of a hill in Leonora. And the reason I put that there is because me being a CSP and a paramedic, I got to learn all this cool stuff. And then once I got to Leonora, I could actually consolidate. And that's when Dylan said, do you want to do a speech? And I said, if anyone wants to listen, I'll have a chat. Cool. So that went far quicker than I thought, which is great. So what I want to do, I want to take you on a bit of a journey. The year is 1978. You're welcome to put your hand up if you're alive in 1978, but some people, yeah, go on, own it. Proud. Proud. There you go. So what was going on in 1978? Well, John and Olivia were at the top of the charts. Staying Alive, also top of the charts. I don't know if they realised it was going to be the CPR song. And those people in the middle, the air hostess back in the day, the flight attendant these days, they showed a lot more leg. And prior to 1940, every flight attendant had to be a registered nurse, believe it or not. Also, United Airlines in the States had just bought a brand new McDonnell Douglas DC-8, worth about $100 million in today's money. $100 million. It was going to be their flagship. They were ready to move on, carry more people around and do it in style. And this was it. So like any big company that's put a lot of cash out somewhere, they don't just want anyone, Bill from accounting, flying their beautiful plane. They want the three best people. There's three people that flew planes back then. Buddy McBroom was going to be the captain. 27 years, 27 hours flight time. You also had a first officer and a flight engineer. Equally impressive resumes. Just to put that into perspective, about 36,000 hours of flight time altogether. Does anyone know, who's good at math? How many years? No one? It's about 4 years of continuous flying. So together, they'd flown for 4 years continuously. So you can see why United thought, let's get these guys to fly our best plane. So, what happened? Well, December 28, 1978, they took off. They were going to do a routine flight, 189 people on board, great weather, no issues whatsoever. They had enough fuel plus 45-minute buffer. And back in the day, back in 1978, 45-minute buffer was normal. So great weather, plane was packed, everyone was feeling good, fuel and 45 minutes. Just before they wanted to land, they went to put the landing gear down, and they've heard on the cockpit voice recorder, they're saying that didn't sound right. So they tried to put the landing gear down, didn't sound right, and they weren't getting an indicator light. That I don't know if there's any pilots in the room. I'm certainly not, but you get an indicator light for everything. There was no light saying it had been lowered. So what do? Well, they are an awesome crew. They said, we're going to problem solve. They requested a holding pattern, and then they spent the next hour trying to problem solve. Does anyone see a problem? So we haven't got that much fuel. At about 1750, the flight engineer is heard in the cockpit voice recorder saying things to the effect of, that'll run us pretty close out here. But at no point did he say, we are running out of fuel. 5 minutes after that, pilot just says to everyone in the cabin, and imagine this, you're coming in for a landing, normal, you haven't heard anything from the pilot whatsoever, you've been circling for an hour, the captain has told you nothing, and he suddenly says, hey team, we'll be landing the next 5 minutes. I'll let you know shortly if you need to be in the brace position when we do. So you've gone from nothing to you might need to be in the brace position. That was the only time the captain addressed the cabin. Air traffic control asked, they thought it was all taking a bit too long, said, when are you going to land? Next 3, 4, 5 minutes. At no point was the ATC advised of any of the issues that was going on. At no point. Who wants to guess what happened next? Three minutes after that, they had their first engine flame out. On the cockpit voice recorder, the pilot is heard yelling at the flight engineer, asking him to transfer fuel from one side to the other because there is no way in hell they've run out of fuel. A minute later, the second engine flames out and the captain says, we're out of fuel. They declare a mayday, they make a crash landing. You can't really see very well the map in the top right-hand corner. They landed a few k's away from the airport. They missed a residential building. I say only 10 people died. I mean, 10 people died, but only 10 people. Could have been a lot worse. So, were they just unlucky? You had 3 awesome people. Were they just unlucky? Well, if that's the case, the 70s had a lot of unlucky pilots. Eastern Airlines, 1972, distracted by a faulty gear indicator light. They became so preoccupied, their autopilot disengaged, and they crashed into the Everglades. They descended, didn't know it, they crashed in the Everglades. Resulted 101 lives were lost. Does anyone know what the cause of that crash number 1 was? The bulb was broken. So they were looking for an indicator light in a broken bulb. Couple of cents. 101 people. Turkish Airlines, loss of control, miscommunication. There was a bit of hypoxia. Lots of people died. Tenerife, people may have heard of this one. 2 747s crashed on a runway due to miscommunication between the ATC and the captain. 583 people. Then there was this one, 1977, which is 1 year before Buddy took off. It's a cargo plane, so only 3 people on board. But just before they were about to land, they had some inoperative landing gear lights. Sounds very familiar. No landing gear lights. A year before Buddy crashed his, or landed it roughly, the crew became so distracted that they quite literally flew into the side of a mountain. So all up, in the 70s, 1,000 people died. Can anyone guess, so that's 10 years, 1,000 people, can anyone guess how many preventable deaths there are in the States, because the States like to keep data, preventable deaths per year in the United States? Preventable deaths, easily preventable. Anyone? About 50 to 150,000. So 1,000 people have died here, and the airline industry is getting very, very nervous because the airline industry, as health, it's $1 billion industry, but if you're sick, you go to hospital. You don't have to catch a plane somewhere. You can go traveling somewhere else. So the airline industry said, okay, we can't keep losing people. We need to do something about this. We can't keep killing people. So what happened? Well, United Airlines put cameras inside their cockpits and they filmed the crews. They filmed the crews and how they interact. And then they got a bunch of psychologists and stuff to have a look and just to see what was going on. So what happened? Well, this isn't official video of inside, but it's pretty close.
Welby, check your final position. I'm going to take her down.
Wait a few more minutes, Captain.
Do as I say.
But it looks like...
Do as I say.
Give him a few more minutes.
I've already waited too long. Here we go.
No, we don't. Get a hold of yourself, you yellow.
So close, but not quite. They found complete poor communication, miscommunication, captain is king, that sort of stuff. And they said, okay, we can't do that. That's not working. What are we going to do about it? They went to a small little company called NASA. And they said, NASA, we're killing people. What can we do? And NASA said, well, we've got this program that's been around for a very long time. You're welcome to have a go. It's called Crew Resource Management. Back then, it was called Cockpit Resource Management, but Crew Resource Management. So United turned around and said, okay, what is it? What's CRM? Well, it's all these fancy buzzwords, but you learn all that stuff and you become a better communicator. That's it. It's about using what you got, becoming a better communicator. So United said, brilliant. We're going to roll it out to all our pilots. And NASA said, no, idiots. You need to teach everyone. What are you talking about? Everyone. Every single person. So everyone from the ground crew, mechanics, CEO, middle management, pilot, co-pilot, cabin crew, everyone got taught this. And everyone on the plane that everyone came over here on, different planes I'm sure, they're still teaching this today. Everyone gets taught this. So what was the outcome? Who knows that guy? Anyone? No one? There we go. What about now? Yeah. You don't know if he hasn't got a plane behind him. What no one really knows about Sully is that prior to landing plane on some water, he owned a business that taught CRM or similar to big businesses, pretty much how to communicate better and to do stuff better and to raise profits and things, I'm sure. So he was a gun when it came to CRM, and he was a gun way before he had to put a plane on water. Very quick, we do listen to something later on if we have time, but what you should know, so a direct result or a direct outcome, and obviously Sully is an exception perhaps, but the pilots, when they, just before they hit the birds, on the voice recorder, they're heard saying shit or birds or something. Within 1 second, they've been hit. They've got birds in their engine. So 1 second. So they couldn't do anything about it. Within 10 seconds, Sully, who was actually co-pilot that day, within 10 seconds, he said the magic words, my aircraft. And that means that he's now in charge. He's the captain, my aircraft. His co-pilot says, your aircraft. His co-pilot's probably saying, you can freaking have the thing, but go for it. I want nothing to do with this. Where are the parachutes? So within 10 seconds, he's recognised that he needs to step up and he's the best man for the job. Best person for the job, sorry. Within 30 seconds of striking birds, Sully has communicated that he might land in the Hudson River. Within 30 seconds of hitting birds, his brain has said, plan A, plan B, plan C is I'm going to land in some water. And he's already communicated that. From strike to landing took about 3.5 minutes. Sully was later asked in a, and I reference a interview with him. He was later asked as an interview saying, did you consider saying goodbye to your family because everything's recorded? Did you consider saying goodbye to your family? You know, love you, kids, blah, blah, blah. And he's far from an arrogant man. And he said, no. I said, why not? He said, because I never believed that I was going to die. I knew that I had the tools to land that plane on the water, and we did that. Oh, goosebumps. Love Sully. Okay. So, cool story. Why are you here? It's a long way of saying that I don't have time to teach you everything I want to teach you. What I do want to do is implant some things in your mind and some tools that I use and some ways that I use them. And then you guys go away and you catch your human factors nerd and start thinking and doing and reading and start just thinking about how you can do your jobs maybe a little bit better. Maybe you're already good at this. I got no idea. I just want you to have at some point an aha moment. Okay, so like I said, long story, but long story short, kind of. This is all about what I do. Just because I do it doesn't make it correct, doesn't make it good. It's just a version of this. So I developed something that I use that I like to use it like an A to E, like an initial assessment, patient assessment, whatever you want to talk about. We're going to discuss, decide, do. I'm just going to keep going round and round and round and round until we get the outcome we want. Then afterwards, the most important part is we're going to debrief. And I've actually heard a few other people, and Mel as well, doing debriefs. I tell you what, 10 years ago when I started, if someone said, let's do a debrief, I would have said, that's lame. But now, after every job I do, when I was in the car, I'd debrief because you learn so much. Before we get to the discuss, decide, do, you can't do any of that unless you've created a team. So it's not part of the actual process, but this is something that you can do in your everyday life, and you have to have an effective team for the rest of this to work. We all heard team is more than sum of its parts and blah, 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 that's fine. But what is a team? What can someone say? What is a team? What's a team? Anyone? Yeah. A team can be, the classic one I go to is Ambo World. Me approaching a triage nurse with a patient, we're a team. We have a common goal, we're a team. Me, that nurse and the patient and whoever I'm working with or whatever, we are a team. We're a few people with a common goal. That common goal might just be to get this patient into resus or in a corridor or whatever, but don't think you need 20 people to have a team. A team is just a group of people with a common goal. So, how do we make a team? I might be telling you stuff you already know, okay? So we'll shoot through this pretty quick. But introductions are so damn important. You just walking up and saying, even to your patient, to whoever, "G'day, my name's Drew, I'm paramedic." It just disarms people. And smile. Quinn, can you come out here, please? Who else noticed some rising tension during COVID? And not just because we thought we were all going to die, but I think it was because we didn't get to smile and disarm the person we're about to see. So, Quinn, just smile for me, mate. How could you be angry at that? Could you ever, 3 a.m., you're a triage nurse, that walks in with that smile? No matter what you've got going on, you want to be his best mate. Can you put that on for me? Now smile. Looks a bit weird, doesn't it? You can kind of see a bit of a smile in his eyes, but you get what I mean. So Thanks, man. Appreciate it. Thanks, Quinn. Look at that. So if we are wearing masks, we all do them now. It makes those other things, those introductions, those, g'day, my name's Drew, how's your night going? It makes them so much more important if you can't just smile at that person. Every team needs a team leader. So I know a lot of us are in this job because we can act autonomously, and now I'm saying let's be part of a team, but it works. So if you're going to be a team leader, be a good team leader. We've got secure and insecure authority. Secure authority is someone who's going to use every single bit of information and person around them to make a good decision. Insecure authority is someone who is more concerned with who is right versus what is right. So just because you're a leader doesn't mean you don't listen. It means you listen more. This is the bit where I don't need it, it's fine. Flat hierarchy. Exchange information, collaborate, collectively solve problems. So this just means that everyone in that room, doesn't matter who you are, consultant, junior, CCP, crit care, first year AMBO, PSA, PCA. I got in trouble last time because someone said, what's a PCA? It's like HSA, PSA, Porter, lots of different names for it. But when I say that, that's what I mean. So we need a flat hierarchy. I'm ashamed to say that back in the day, we used to be a bit of a saying go round. It was DYT, do your time. In other words, don't talk unless you've actually done, 5 years. That's, Dylan's laughing. That's different now. I don't care who you are. I don't care, because I don't know what your background is. So everyone has a voice. And team intelligence, creating psychological safety, and that just means that you need to be able to speak up without being concerned that you're going to get laughed at. That's all. So just be kind. If someone says something that it doesn't make sense or whatever, either ask more questions or just be nice. Be kind. CRM teaches us to exercise authority in a way that makes people want to take notice. You could be the most shit-hot clinician in your cohort or whoever. In my world, the clinical support paramedics, you could be the smartest, friggin' best CSP, but our job was to go and back up crews. So you could be the smartest dude in the room, but if that crew doesn't want you in the back of their truck, it doesn't really matter, does it? Unless people want you to be a part of their team, it doesn't matter how friggin' smart you are, because no one's going to want you to be part of their team. Okay. So we've made a team. We're part of a team. We're a team now. Everyone feels happy. They can speak up if they want to, shout out, throw things, whatever you want to do. So now we've been faced with a problem, and I don't have a hypothetical problem. We're just going to talk about it as a general. We're going to discuss it. We've created a team. We're going to discuss the problem. First thing, we're going to brief the problem. If you have time to take a deep breath and to think about what you're going to say, do it. It's a bit like from Ambo World, and I'm sorry, I keep doing it. If you're going to take someone in on priority and you want to do a handover or a patch phone, I always tell people, say it once in your head before you say it on the phone. So if you have time, done. Be brief. A brief should be brief. People lose interest very quickly. The silent cockpit. So if you're talking about a patient, don't interrupt. And I could say that about, from both sides, if you are answering patch phone calls, let us get the patch done, because as soon as you interrupt me, I've lost my train of thought. So silent cockpit is pretty much when you're taking off or landing, only things that directly correlate with what's going on right now matter and can be talked about. So only the problem in front of us is what we're going to talk about. Don't forget, courage is contagious. And we all know this, speaking to patients that don't like us. Just seen one yawn. Okay, Ask for solutions. Everyone should be included. Police, bystanders, family, PCAs. This is where I got in trouble last time because PCAs, no one knew what they were. So they are, everyone knows they're porters. Is there other words for them? Hey? Orderlies? Orderlies, yeah. Wardies, someone said last time. Wardies? I don't know. I was mentoring a brand new, I hate war stories. I think there's only one of them, that's fine. I was mentoring a brand new AMBO. So he was junior AMBO. But he also had, obviously, background. He came in mature age student and stuff. So we were taking a unstable cervical fracture in a child to our state kiddie hospital. Unstable, so everyone was a bit like on edge. We got there, heaps of people met us. Great, no worries at all. We needed to slide this kid from A to B and to do it without causing more harm, obviously. Everyone, too many cooks, is it too many cooks, too many chefs, whatever, too many cooks. Everyone was saying how we should do it, what we should do, arguing, whatever, blah, blah, blah. I knew that the person I was mentoring had also been a orderly for 5-6 years. So it lived and breathed this shit. I turned around and I just said, Dave, do you have anything to add? And as soon as I gave him that in, he was like, absolutely. Let's do this. Bang, 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 bang. He was the best person for the job, but he currently didn't feel like he could put himself in that position. He had to be invited in. You don't know what you don't know. There's plenty of fireys that used to be paramedics, because in WA they definitely do sleep a bit more. I don't know if it's our fiery here from actually does work. She's not here? Sure. Got locked out of his room again. Yeah. You don't know what you don't know. Shared language, that just simply means if you're with a police officer and you want them to hold on to an ETT, just say, can you hold that tube or watch that tube or something like that. Don't say, don't touch the ETT, because they'll be like, what the fuck's an ETT? So use that shared language. Using a shared simplified language has been shown to cut down on stuff-ups. I know as medical people, we love to use big words. There's a time and place. Just don't use it all the time. If you have other people inside that they just don't know what you're talking about. Risk reward. Everything in my life just about is risk reward. You've got to do the least to achieve the most. And this is when we'll talk about in a moment, making a plan. Your plan A should be low risk, high reward, and you go from there. Cool. Don't think I've forgotten anything. How can we do this better? Be clear, don't just send and acknowledge. So send and receive. So, line up, IV access, patent 1755, copy, patent access 1755. Like, don't just say, copy, roger, yep, done, whatever. Don't just send and acknowledge, send and receive, and make sure that person knows that you've actually heard what they're going to say, especially if it's important. Avoid the hint and hope. Who was it? Flight engineer, Rod. He was hinting and hoping, getting a bit low. Getting a bit low. No, yeah, it was getting a bit low. Nothing about, guys, we're about to run out of fuel. I've heard it a million times. Oh, SpO2 is getting a bit low. What does that even mean? Be specific, especially if it matters. Be concise. Just say what you need to say. Brilliant. Be timely. This is something I'm hugely passionate about. And again, it's about creating that flat hierarchy and all that sort of stuff. Making people know that they can talk. If you see something, say something. I don't care who you are, what you do, what level you are, whatever. If you see something, especially danger, but if you see something, say something. Everyone should feel comfortable enough to be able to put the hand up and say, don't do that. All right. We've discussed our problem. Now we need to decide what we're going to do. How do we decide what we're going to do? Who was it? Always have a plan A and plan B, obviously. Always have a plan C. Plan C should be making that patient safe. and then we can just go back to discussing again. So plan C should be what we need to do to make that patient safe while we talk a bit more about it. Sully had a plan C within 30 seconds. He's phenomenal. I'm not saying everyone needs to. But Sully had a plan C within 30 seconds. Within a role I used to do, we'd send helicopters. Helicopters love to have warning lights, and they love to not actually get to the job that we send them to. So you always have to have a plan C, because that helicopter didn't always get to where we wanted it to go. Appoint duties. Use names or their role and make people be directly accountable. I don't think there's anything wrong with saying airway, because I don't know your name or whatever. Airway, happy or not happy? Airway, good or not good? I don't think there's anything wrong with that. If you know their name, brilliant. If you don't, use really good eye contact, use their role, and make sure they are accountable. So when you're giving your plan, you can say, airway, if you are suctioning more than you deem appropriate, you need to tell me straight away. Make them accountable in a nice way. Clear transition. We have a plan A and a plan B for a reason, because when plan A doesn't work, we go to plan B. When plan B doesn't work, we go to plan C. Be clear on when you're going to move to plan B. And that might be if you're tubing, you've got you're intubating, whatever, if SATs get to this, we stop. Cannulation is a big one. I'm just going to have one more go. I'm sure I'll get it. No, it's time for friggin' IO. Okay. But have a plan, stick to it. And it often helps if it's a team decision. If you voice that your plan A is this, your plan B is this, and when it comes time to move to plan B, if multiple people know what that is, they're going to say it's time to move to plan B. Then it's a team effort. Everyone is being accountable. Verbalise everything. Absolutely. I'm brilliant at verbalising on jobs. I'll say, IV access at whatever time. I'll never write it down, but I always verbalise. But then someone else normally writes it down, which is great. I'm always jealous of EDs who have a scribe. I would hate to be the scribe because I can't write, but I'm always very, very, very jealous. Rely on your team, be hands-off. Within the AMBO world, we look at who the team lead is, shouldn't be touching the patient, whether they take their gloves off. I toyed with the idea of bringing a clipboard around, but within hospital, team leader should be at the head of the bed, not touching. There's most often going to be a breakdown in communication. It will hinder progression. Just be aware and then just get back on top of it. It really helps if your team has buy-in, if people believe that this process works. You are going to have people that just don't want to be a part of it. That's okay. Don't spend precious time trying to get them to have buy-in. If they want to go and sort out something else, get something out of the drug cupboard or go organise extrication, just let them. You want the people that want to be there to be there. A leader leads. So we've talked a lot about nice hand-holding, flat hierarchy, all that sort of stuff. But in the end, the cockpit is not a democracy. There needs to be a clear team leader. And it's definitely shifted in the last sort of 10, 15 years, definitely. We now know that having a leader works. So, now we've discussed, we've decided we're going to do it. There is a million ways to do it, but I want to introduce you to something that some of you may or may not know. Has anyone heard of the surgical safety checklist by World Health? Nope. No one? Pretty remarkable. If you haven't read the paper, you should read it. So, doctors from the World Health sought advice from Boeing. Why Boeing? Because after everything that happened and they all got their CRM stuff done, Boeing became really, really, really good at threat and error management, and that included doing checklists and reducing that cognitive load. So this is one way pilots have a ton of checklists no matter what's going on. It reduces that amount they have to actually think. Went to Boeing, they said, we want to develop this. Brilliant. 19 items all up, takes 2 minutes to complete. In 2007, It was rolled out to 8 hospitals, varying levels. So we had all around the world, as well as rich, poor, everything. They tried to get a nice, even mix. The outcomes were so astounding that the authors spent the next year or two trying to disprove themselves because they thought we've made a mistake somewhere. So about 4,000 patients ended up being a part of this program using the checklist. They had a reduction, nearly 50% in deaths, 36% in complications. About 150 people were spared from harm, and 27 people didn't die because a 2-minute checklist was read before someone had surgery. So, checklist is one of them. We already use them, and there's different types. We've got a bunch of examples. And if you've got any suggestions, go for it. I'm just getting the wrap up, so we're going to go forward. Things to consider. While you're actually doing this, really good communication. In aviation, they'll say go and no go. If you're about to do a transfer and you've got someone tubed, okay, we're going to take this person from here to here. Airway, you would go, no go. Okay, we stop. Nice, clear, concise. Plans change, avoid confirmation bias. This goes back again to, I'm pretty sure I could get the next line. I'm pretty sure. 17 attempts later. Move to plan B when it's agreed upon. Make it a decision, team decision. Plan C isn't a failure. We removed things like the failed intubation drill because it said failure. It's not failure to intubate, it's a difficult airway. So now it's difficult airway trolley or kike or whatever it is. But Plan C isn't you guys saying we screwed up and we're not good enough. It's saying that we've tried everything we need to do. Now we need to go back, make this patient safe, just start the process again. What is our problem? Okay. So what I want to... Well, what I want to do now, quickly, we're just going to listen to the air traffic control. It's going to be a bit hard to see. I will talk a little bit. It's Sully.
Every day.
Here, Johnny 2760, 5,000, turning your right to 150.
Johnny 2760, climb maintain 10,000.
10,000, Johnny 2760.
Birds, bam. Uh-oh. We got one both rolling back. The engines were stopping. Starting the APU. My aircraft, your aircraft. Get the quick reaction handbook.
Cactus 15.9, turn left lane 270.
This is Cactus 1539. Hit birds, we've lost thrust on both engines, returning back towards LaGuardia.
Okay, you need to return to LaGuardia. Turn left heading up 220.
220.
Tower, stop your departures, got emergency returning. It's 1529. He bird strike. He lost all engine. He lost the thrust in the engines. He's returning immediately.
Cactus 1529. Which engines?
He lost thrust in both engines. He said.
Got it.
Cactus 1529. If we can get it for you, do you want to try to land 1013?
We're unable. We may end up in the Hudson.
Already communicated. Might be in the Hudson to ATC.
Johnny 2760. Turn left 070.
Johnny 2760.
They're trying to get the engines restarted, and they're going through a checklist.
Hi, Cactus 15.9. It's going to be left traffic to runway 31.
Unable.
Okay, what do you need to land? Cactus 15.9. Runway 4 is available if you want to make left traffic to runway 4.
I'm not sure we can make any runway. What's over to our right? Anything in New Jersey, maybe Teterboro?
Okay, yeah, off your right side is Teterboro Airport.
Listen to this one.
Do you want to try to go to Teterboro?
Yes.
Teterboro, Empire. Actually, LaGuardia Departure Guy, emergency inbound.
Hey, guys.
Cactus 1529 over the George Washington Bridge. Wants to go to the airport right now.
Wants to go to our airport. Check. Does he need assistance?
Yes. It was a bird strike. Can I get him in for runway 1?
Runway 1, that's good.
Cactus 1529, turn right 280. You can land runway 1 at Teterboro.
We can't do it.
Okay, which runway would you like at Teterboro?
We're going to be in the...
I'm sorry, say again, Cactus? All right.
So at that point,
Kelly 2760, contact New York 126.8.
The traffic control, they can no longer help me, so they're done. They're gone. I'm not talking to them anymore. Now it turns to trying to land.
Cactus
The whole time they're getting these warnings,
You also got
terrain,
Newark
terrain,
Airport
pull
up to
up,
2 o'clock
terrain,
in about
terrain,
7
pull
miles.
up. Because the air traffic controller never got to, all he's watching is like this. He thought they crashed. As soon as they crash, they take these traffic controllers, air traffic controllers, they take them to a separate debrief room because they don't want to be part of anything anymore. So it took him, I think, 45 minutes to realise that that plane had landed safely. The whole time, he thinks that people have died and it's, he's got something to do with it. And then he found out that they obviously survived.
You can fly 4718, climb maintain 12000.
12000 and you can fly with 288.
And you can fly 4718, I'm sorry, I missed that. Say again?
There you go.
And we're...
Sully obviously copped a lot of crap after that. They thought that he could have gone to Teterboro and other things, but they put a bunch of pilots in simulators and no one could land it. So he got done. 2 minutes? Do we have 2 minutes or not? Yeah. So I've left the last bit, the most important bit till last, and I've only got 2 minutes, so we'll run through it quickly, but hopefully it's self-explanatory. I was listening to Professor Fiona Wood speak not that long ago, and she said the only bad decision is one from which we learn nothing. It is a Henry Ford. But I thought, that's freaking awesome, so I'll put it in there. Debrief. Keep them simple. Stop. So I use the Edinburgh Emergency Medicine one. Stop, do your check-in. Number 2, summarise what went well, how can we improve, points to action and responsibilities. That's it. Nice and simple. This is not meant to be a mental health check-in. This is a work check-in. We gain nothing by doing debriefs and just holding each other's hands and saying we all did brilliantly. This should be a safe space. Fatigue, diet, personal life, it all comes in. In aviation, if you're having a bad day, you tell your partner, because if they need to step up, it's something we should do in healthcare as well. Done. Whoops. Yeah, a few books. Sully, done. 46? Yeah, not too bad.
Awesome. Let's hear it for Drew. Does anyone have a question that they'd like to ask Drew? I'm going to throw him in it and say that he'll be more than happy if anyone would like to come up to him at the end of the session just to have a quick chat about anything that you've heard there, or if you'd like any of the recommendations of where he's got this info from. Just before we finish up, I just want to say a really big thank you. On Tuesday, we had a number of participants that joined the hospital tour. It was a great success. We felt so welcomed into the hospital and they really went to a lot of effort to accommodate us all there. We actually have some staff, including the head of the ED at the Siloam Hospital. And so can we just give a big round of applause to Siloam Hospital for hosting us there? That draws things to a close for today. Same place, same time tomorrow. Don't forget with the closing party, it's going to be a 7:30 start. If you would like transport organised for you from the Trans on our little shuttle bus that we'll have running, please see Max and Delphine at the back. They'll hook you up to let Choc know that you'll have a spot on the bus. Apart from that, enjoy the night and we'll see you back here tomorrow. Thanks, guys.